Welcome. Today, we're on the inside of a forensic investigation. We're looking at a case that's all too common, but incredibly difficult. The mind that goes offline after a perfectly executed surgery. We are going to unravel the cellular and molecular evidence behind perioperative neurocognitive disorders. You know this scene. The operation was textbook. The patient is stable, but post-op, they're confused, they're disoriented, their cognition is just gone. It's that frustrating gap between surgical success and cognitive failure that we are going to close today. So our investigation is going to tackle two really critical questions. First, how can a simple blood test taken before surgery actually predict a patient's risk for this cognitive breakdown? And second, what is the key imbalance in the immune system that turns a normal, expected inflammatory response into long-term cognitive damage? Now, our analysis today brings together findings from some really cutting-edge research published in journals like CNS Neuroscience and Therapeutics, Aging Research Reviews, BMJ Open, Frontiers in Cellular and Infection Microbiology, and Neuroimmunomodulation. As always, the links to the full bibliography are right there for you in the description below. Okay, here's our game plan. We'll start by looking at the scale of the problem, what we're calling the silent complication. Then we'll follow the evidence trail as the brain's defenses are breached. We'll uncover the key immune imbalance, the inflammatory seesaw, examine anesthesia's role, and then wrap up with a practical clinical playbook. Let's start by just establishing the stakes here. This isn't some rare event. It's a silent but incredibly widespread complication. The sheer numbers are pretty staggering. Up to half, that's 1 in 2 of our older surgical patients will experience some form of PND. At discharge, that number is still a massive 40%. And for almost 13%, this isn't just a temporary fog. It is a persistent cognitive deficit that's still there 3 months later. And that leads us to our first major piece of evidence, a protein called Neurofilament light chain, or NFL. The best way to think about it is like the structural rebar inside a neuron's axon. When that axon gets damaged, NFL leaks out into the CSF and, importantly, into the blood. That makes it an incredibly sensitive biomarker for ongoing neuronal injury. And here's the clincher. A meta-analysis in BMJ Open found that high levels of NFL before the patient even sees the inside of an OR is a major risk factor for developing postoperative delirium. What this tells us is that for many of these patients, the brain is already fragile. There's a pre-existing vulnerability that the stress of surgery is about to unmask. All right, let's move on. We have a vulnerable brain. So how does surgical trauma way out in the periphery cause total chaos in the central nervous system? Well, it happens through a direct breach of the brain's primary defense system. It all kicks off with systemic inflammation. The surgical trauma releases a storm of damaged signals and cytokines, things like IL-1 beta and TNF-alpha. This inflammatory soup is like a chemical attack on the walls of a fortress, the blood-brain barrier, and it starts to weaken the tight junctions. This breach allows neutrophils, the immune system's aggressive first responders, to squeeze through and invade the brain. Once they're inside, they release destructive agents like nets, causing even more damage. And all this commotion alerts the brain's own residential guards, the microglia, who then get activated and just pour more fuel on the neuroinflammatory fire. Now, that initial attack by the innate immune system, that's only the beginning of the story. For the cognitive damage to stick around and become persistent, a much deeper problem has to occur within the adaptive immune system. And this is the absolute heart of the matter. Picture the immune response like a seesaw. On one side, you've got the pro-inflammatory T17 cells. They're the accelerator. In PND, their numbers just go through the roof. On the other side, you have the anti-inflammatory regulatory T cells, or TREGs. They're the brakes. Post-surgery, their numbers just plummet. So the accelerator's floored and the brakes have completely failed. This profound, unchecked imbalance between T17 and TREGs is exactly what pushes acute inflammation into chronic, brain-damaging neuroinflammation. This image gives you a sense of just how complex this cellular battlefield really is. You can see microglia, monocytes, different T cells all playing a part. But even though the network is intricate, the central story is crystal clear. It's the dysregulation, especially that Th17/Treg seesaw, that decides the outcome for your patient's brain. So where do we as clinicians actually come into this? Well, our choice of anesthesia is not a passive one. It is an active intervention that modulates the immune system. This table gives us a really high-yield snapshot. Volatile agents like sevoflurane, their effects are complex. They can dampen some pathways, like TLR4, but their overall inflammatory potential is pretty mixed. Compare that to intravenous agents like propofol, which has potent anti-inflammatory effects and directly suppresses that microglial activation we talked about. And then, of course, you have regional techniques, which by their very nature can dramatically reduce that initial systemic inflammatory wave that starts this whole cascade. And that brings us to our final and maybe most important section. How do we turn all this mechanistic knowledge into a concrete clinical playbook? Here are 3 key actionable takeaways. Number 1, assess pre-op vulnerability. That preoperative blood NFL level can be a flag for patients with that underlying neuronal fragility who are going to need closer watching. 2, mine the T-cell seesaw. When you see that persistent cognitive decline, your thinking needs to go beyond the initial inflammation. The root cause is likely an ongoing T17/Treg imbalance. And 3, choose anesthesia wisely. See your choice as a real opportunity to modulate the patient's immune response. Consider propofol or regional techniques to help blunt that inflammatory hit. If you take just one single thing away from this explainer, make it this phrase. It's a simple way to frame the issue with your colleagues. When you see post-op brain fog, your first thought should be, check the inflammation log. As the researchers here conclude, this knowledge isn't just academic. Understanding these neuroimmune interactions is our direct path to developing targeted therapies. It empowers us to move from just reacting to PND to proactively managing the neuroimmune axis, to protect our patients' brains, and to fundamentally improve their surgical outcomes. Disclaimer and bibliography in the description.